Welcome to week 8, everybody. I hope that you are doing well and starting to gain more confidence in your comfort and understanding of the respective categories of disorders. As I've mentioned before, and will continue to emphasize, find time to connect with other students in the class, and to do this for the benefit of role-playing the various disorders in the DSM. It helps to have a fellow student offer you a story about what brings them into therapy, drawing from the diagnostic criteria in the DSM, but in a narrative form. And then you have the opportunity to attempt to determine through your questions, through their statements, what the diagnosis is. You'll find that this enables you to practice hearing the important elements and knowing where to go next with that information. So I'll keep emphasizing that, but enough about that for now. Let's get started with this week's diagnostic categories. In this grouping of disorders, we're going to be reviewing schizophrenia and other psychotic disorders. In this first slide, we're learning about schizophrenia spectrum disorders, which includes your schizophrenia, your psychotic disorders, and schizotypal disorder, which you'll remember is a personality disorder, and a prodromal disorder for schizophrenia. 5 symptoms need to be present. They're going to be the positive symptoms, the negative symptoms, and then abnormal motor behavior. We're going to delve into each of these 3 groupings more, but for now, let's focus on the positive symptoms, which include your delusions, your hallucinations, and disordered thinking or speech. Okay? Effort to help you understand how to distinguish the positive from the negative symptoms. It helps to think about the positive symptoms as symptoms or behaviors that are present, i.e. positive, right? But that should be absent. Stated differently, these are behaviors that are unexpected and atypical, but are showing up anyway. When we're thinking about schizophrenia, for instance, the symptoms that are most identified with the disorder are likely going to be the positive ones. They are obvious and account for much of what is typically observed in sufferers of this condition. About 50 to 70% of individuals with schizophrenia are going to be exhibiting the positive symptomatology. And so that includes, again, your delusions, your hallucinations, and your disorganized thinking and speech. So what are the positive symptoms? One of the positive symptoms is the presence of delusions. These are going to be those fixed thoughts or fixed beliefs that don't respond to evidence to the contrary. Now, there are different themes of delusions, like persecutory, which is going to be similar to a paranoid mentality. Your persecutory delusions are ones where there is some fear of being harmed by other people. Such a delusion may make being open to getting help or getting treatment more difficult because of the uncertainty about the intentions of other people. Okay, so if a person is struggling with a delusion of a persecutory nature, we are expecting that they may be less open to treatment. Grandiose delusions may sound familiar also, as there is an element of this with narcissism. It entails that belief of superiority and exceptionality, or even infamy. A delusion of reference is the belief that things are specifically directed at self. For instance, the song on the radio was intentionally played to send me a message, or the billboard that was just passed on the expressway has some special meaning just for me. Okay? Now, the other delusional themes are here for you to familiarize yourself with: erotomatic, with regard to love, nihilistic, being convinced that some catastrophe is about to happen, and then your somatic delusions, where they are preoccupied with a specific organ or health in the body. Also listed as a positive symptom are hallucinations. These are the perceptual experiences that have to do with all five senses: hearing, tasting, touching, seeing, and smelling. It's important to note that these experiences, though not present for others, are clear and vivid for the person experiencing them. So they create an impact even though they are not real to anyone else. They feel real, they are experienced as being real for the sufferer, and they're not under the voluntary control of the sufferer. Auditory hallucinations are probably the most common in schizophrenia, where the person is hearing a voice or voices that are not their own, but that seem to come from outside of them, like somebody is talking, versus being internally manifested like a thought. Okay? As has been mentioned before, when we're thinking about hallucinations, context and culture are important to consider, because hallucinations might be a part of the normal religious experience or a meditative experience. Okay, so we want to have full context and understanding about the circumstances under which the hallucination presented. When I do these recordings, it's not usually the case that the audio file that I include in the video actually records in totality for the video lecture. So when you view this particular slide, but from the complete slides where it's just the PowerPoint slides, you will be able to hear this example of auditory hallucinations. I invite you to step away from the presentation, going from slide to slide, to just sit with and focus solely on this particular slide, listening to what you're hearing and ensuring that you place the audio at a volume that's not too loud, but that it seems to be playing in the background. And while this is playing in your ear, listen to it on repeat while trying to have a conversation with another person, or while trying to read or watch TV. Maybe you're trying to complete paperwork. Take note of the difficulty, the disruption, whether or not you're able to concentrate with these voices playing in the background. How does the experience make you feel? What thoughts come to mind when the auditory hallucinations are playing through your mind? Now consider how a person who is hindered by auditory hallucinations might feel, and how disruptive is this experience. We know that medications can be given to quiet the voices, and notice that I stated quiet, because many sufferers indicate that the voices don't go away completely even with medication. Instead, they may recede to the background as inaudible noises. But for many, they don't go away completely. Imagine the difficulty and distress of not being able to get relief from involuntary voices in your head. We've reviewed and gotten understanding of the positive symptoms, those behaviors and thoughts that are most salient and observable to schizophrenia, those behaviors that are unexpectedly present. The negative symptoms are the opposite. They reflect behaviors and symptoms that should be seen but are not. They are absent behaviors that should be present. The absence of expected behaviors can be quite unsettling for family members to experience and then to manage. So they include those things like emotional expression. So in a person suffering with schizophrenia, emotional expression and reciprocity are absent, right? Prosody or tone of speech is absent or flat. Movements that might offer meaning to emotion are absent. Okay, so just think about if you are engaging with a person and you're expecting reciprocity and prosody, and all of that is absent and is exchanged for a flat, monotone, expressionless, still conversation. In addition to there being a lack of emotional expression, there may also be a sense of apathy that is displayed, where there's no initiation of activity, and instead there's stillness for extended period of times, like a catatonia. There may be little speech at all for some, and there might also be an inability to experience positive emotion. And finally, when we're thinking about negative symptoms, we are considering little to no social engagement. The fifth symptom, which is germane to schizophrenia, are those that connote a disorganization of thought and speech. Now, I'm emphasizing here a disorganization of thought and speech because that's separate from the behavioral disorganization that's associated with negative symptoms. We notice with disorganized symptoms are that speech patterns and ideas are unusually articulated and formulated. So the speech might be tangential, meaning that the connection between thoughts is rather loose, such that the connections are not obvious or even clear. The thoughts may be conveyed through words that are jumbled and disconnected. Sometimes this is referred to as word salad. So I've given a definition here because it's confusing, sometimes unintelligible, but it could be something like the best, highest purple, and the opposite of fast could only justice for the cats that rummage sale expensive. You can see how there's no connection in any of those words. It just becomes a collection of words, but where there is no real shared meaning, and that would be a word salad. Importantly, this symptom, this disorganized thinking, can occur during prodromal periods, that preceding time of deterioration between the onset of the psychotic symptoms, or during the residual period, which is following a schizophrenic episode. So this disorganization in thinking could present just before the onset of a full schizophrenic episode, including both the positive and negative, or it could come after the episode ends. Not only are thoughts disorganized, but behavior is also disorganized. Here, disorganization is represented in the manner of behavior. So there's silliness or agitation that's unexpected or even unpredictable. The person might also appear to be catatonic, meaning they're unmoving or they are evidencing significantly decreased reactivity. Okay, so how would this look? It would present as rigidity or bizarre posturing, an absence of verbal or motor responses. Okay, and the disorganization could present as movement that seems to lack purpose, or it could be stereotyped movements like a rocking, for example. Okay. Finally, there might be evidence of echoic speech, which is a repeating back what is being heard. So what is this? For instance, someone might ask, "How are you doing today?" And the person would repeat, "Doing today," right? So it's an echoing of words that might be considered part of this disorganized motor behavior. Hopefully, you understand and can distinguish between the positive, negative, and disorganized symptoms of schizophrenia spectrum conditions. Now, we're going to look at the disorders that comprise this grouping now that we have that understanding. The schizophrenia spectrum disorders include your schizotypal personality disorder, which, as you'll remember, is a cluster A personality disorder, and again is considered to be prodromal. So it is both a personality disorder as well as a schizophrenia spectrum disorder. We have delusional disorder, brief psychotic disorder, schizophreniform, schizophrenia, and then schizoaffective. We also have the other groups of substance or medication-induced psychotic disorder, and then psychotic disorder due to another medical condition, right? So, like the other categories, you have these due to another medical condition or due to a medical condition, and then some substance or medication induced. Of this category of disorders, schizotypal, like I said, should sound familiar because it's also discussed with the personality disorders. As a reminder, schizotypal personality disorder is that pattern of social deficiency that results in the person being uncomfortable and disliking the social deficit and the impact that it has on relationships, right? So remember, there was the schizoid and the schizotypal. The schizoid, who doesn't really care about relationships. The schizotypal was the person who's very much interested in having relationships, but evidences social deficiencies that make having relationships unlikely. Okay, the odd behaviors and thinking are sort of common to this condition, and it includes the magical thinking, the paranoia, perhaps the odd appearance, and eccentricities. Perceptual disturbances might also be present. So we can understand how it could be prodromal, thought to be prodromal to a schizophrenia, which we will learn more about here in the upcoming slides. The next disorder in the schizophrenia spectrum conditions is delusional disorder. It's marked by fixed beliefs that go unchanged despite evidence to the contrary. In other words, what the person believes to be true can be proven otherwise, but still the person is insistent on maintaining this belief. Okay, we went through these a little bit before when we were talking about describing the positive symptoms and delusions being one of those. The types are the same, but Here, it is a disorder that is just comprised of delusional thinking. If somebody had a delusional disorder, we would note if the thinking and believing was bizarre, meaning not likely to happen or uncommon for that culture. Again, we see that context, culture comes in, right? So the belief has to be uncommon for that person's culture. The belief has to be present for at least 1 month or longer. And if we think about this time frame, it actually allows for a period of time where the belief might have opportunity to be debunked with some sort of disconfirming evidence, right? So we know that sometimes there are things that we hear and believe. But once we recognize that what we are thinking and believing is really implausible, right? And the evidence is to the contrary, if we hold firm to that belief, we are meeting criteria for a delusional disorder if it persists for a month or more. We want to ensure that criteria is not met for schizophrenia, which includes the other positive symptom of hallucinations, right? And the negative symptoms and the disorganization, which is all absent in a delusional disorder. So as we're going through these, you'll notice that each of these schizophrenia spectrum disorders have pieces of those five original, the positive, the negative, and the disorganized, okay? Beginning with the delusional disorder, it just has the delusions, right? But it doesn't have the other things. With this disorder, though, there can be mania or depression, but those experiences or episodes are generally brief, but they're related to the delusional occurrence, okay? The delusion could not have been brought on by substances or a medical condition. If that's the case, then we're going down to the bottom two categorizations, psychotic disorder due to a medical condition or whatever, but we wouldn't give it a delusional disorder. Also, if there is body dysmorphia, which has a delusional-like aspect in the person's inaccurate perception of their body, if body dysmorphia is related and the belief, the thing that seems implausible and for which their evidence does not support, is related to how the person sees a part of their body, we're not going to go with a delusional disorder. Instead, we would go with a body dysmorphia, okay? And then also OCD, those thoughts that persist, that contamination is present, or those sort of things. Those sort of beliefs exist, but when it happens in the presence of an obsessive compulsive disorder, we are then giving that disorder instead. Here, the content of the delusions is listed. We went through those in an earlier slide, and they're pretty self-explanatory. A mixed content delusion suggests that there isn't a dominant theme amongst the delusions, and a person could have more than one. If the content of the delusion is uncertain, then unspecified would be used, okay? So you have the same bold-faced descriptions as the earlier slide, but we do have mixed and unspecified here. Like other conditions, we have the specifiers, and as we already noted, will indicate if the content of the delusion is bizarre, meaning it's implausible, not a function of ordinary life experiences or something that is culturally expected. We will note if there have been multiple episodes of delusions and whether or not there is a current and acute or active delusion. or whether or not the delusion seems to be subsiding or is totally distinguished or extinguished. That's where we get into our partial remission or full remission. For some, the delusional belief is continuous and doesn't relent. Sometimes also we are unable to determine these details, and so we would go with unspecified. Okay, you can see that at the 1 year mark, we're going to indicate if it's a first episode or multiple episodes and whether or not it's currently acute or active, and partially remitted with improvement or improvement that's been maintained. For full remission, we're looking for the absence of symptoms for at least 1 month. So you have to have the delusion for at least a month, and full remission is that same time frame. Now, let's move on to brief psychotic disorder, which is also part of the schizophrenia spectrum conditions. Notice from this slide that this particular disorder only entails the positive and the disorganized symptoms that we discussed, but not the negative symptoms. Okay, so this is psychosis. And in a brief episode, we know our psychoses are delusions and hallucinations. Okay, so it has that, but it also has the disorganized speech, thoughts, and motor disturbance. Okay, there is the presence of one or more of those that meets diagnostic criteria. You could have just a brief episode of the delusions, right? So we just had delusional disorder. You could have a brief psychotic disorder that is just the delusions, right? Or it could be delusions and hallucinations, but it's brief, meaning it lasts from 1 day to less than a month. Remember, the others, the delusions, had to be present for a month. This is brief, and it's from 1 day to less than a month. Once we hit the 1 month, we're now looking at and considering the presence of something else. If it's a delusion, then we're now considering a delusional disorder because that requires the presence of symptoms for at least a month. We'll want to ensure that the behaviors are not a function of a depressive or bipolar disorder with psychosis. Okay, I know that may sound confusing, but the crux of the issue is the psychosis. However, with a depressive disorder with psychosis or bipolar disorder with psychosis, the main crux of the issue is the mood that happens to have a psychotic feature. Let me pause here to highlight what I hope you're noticing. Schizophrenia spectrum disorders are only given after other conditions have been ruled out. If something else can better explain the symptoms, then that is the diagnosis to be given. Okay, thus far, each of the disorders carries with it some aspect of those 5 symptoms: positive, negative, or disorganized. Either just the delusional content of the positive symptoms in a delusional disorder, or the positive and disorganized symptoms in brief psychotic disorder. With schizophreniform disorder, we more closely approach schizophrenia in that there is the presence of positive and negative, the positive and the negative symptoms, along with disorganized motor behavior. So this is a buildup from the brief psychotic episode, from a time standpoint, and from symptom add-ons, okay? Here, though, We've passed the 1 month mark of a brief episode, which extends from 1 day to 1 month. With schizophreniform, the symptoms last from 1 month, but less than 6 months. Okay, and they include the disorganized symptoms. The brief psychotic is only the positive and the disorganized, but not the negative. I know this seems a little confusing, but it sort of builds up to the schizophrenia. The differential diagnoses are listed here, indicating the conditions that may share symptoms, but that might also better explain what is being seen and presented. Because of the differential to schizoaffective disorder, which is upcoming in an upcoming slide, there is consideration for the presence of mood episodes. With schizophreniform, here, the mood aspect is a minor aspect of the total time of suffering. Okay, so you can have a mood component, but it's really minor in a schizophreniform. Okay, finally, we arrive at schizophrenia. All of the symptoms are present for a schizophrenia diagnosis. To meet criteria, 2 or more of your positive, negative, disorganized symptoms need to be present for most of the time during a single month, okay? And present such that level of functioning is less than before the symptoms presented. The duration of the symptoms for schizophrenia, though, have to persist for at least 6 months compared to the reduced symptoms of a brief episode, which is 1 day to 1 month, or the schizophreniform, which is also reduced symptoms from 3 months to 6 months. So, yes, you are having these most of the day during a single month, but these symptoms are lingering for 6 months. But it doesn't have to be for most of the time during that 1 month, like it has to be for the single month. As before, prior to landing on a schizophrenia spectrum disorder, other disorders have to be ruled out first. Here, you're ruling out the potential differentials of schizoaffective, depressive, or bipolar disorders with psychosis, okay? And of course, if there's a medical condition or a substance being used, this disorder is not going to be given. If there's a history of autism spectrum or communication disorder, then full criteria for schizophrenia has to be met, with the prominent features of delusions and hallucinations being obvious for at least 1 month. So when we think about the when we think about the negative symptoms, the absence of speech and emotional reciprocity and prosody and those sort of things that could be present or seem to be present for a communication disorder or even autism spectrum, right? So in order, though, for it to be a schizophrenia, you have to have the psychotic features, the delusions, or the hallucinations. Otherwise, the absence of that, you could be looking at autism or a communication issue. Hopefully that's clear. Symptoms can be common with schizophrenia. However, differentiation from a mood disorder with psychosis is that schizophrenia requires the presence of delusions and or hallucinations. Your mood disorders do not require the presence of delusions and hallucinations. There's often a lack of self-awareness with schizophrenia that is going to make treatment compliance more difficult. So that's worth noting with this disorder. I have in here about the percentage of the population and then early adulthood as the onset, and it tends to be slow and gradual, which makes room for that prodromal symptom. Finally, we land on the last disorder in the schizophrenia and psychotic disorders, and it's schizoaffective disorder. This one is a two-part condition that is equal parts psychotic, which is the schizo part, and affective, which is the mood part. The psychotic symptoms that are present with a schizophrenia diagnosis are coupled with mood symptoms like a bipolar disorder and a depression disorder. In order for the diagnosis to be schizoaffective, the symptoms of psychosis and mood are present at the same time for part of the episode. In that same episode, though, there is a period where there is just psychotic symptomatology, and there is a period of time where there is just mood for a substantial part of the episode. Okay, so the schizo and the affective, the psychotic and the mood are happening at the same time, but there is a period of time where there is just psychotic symptomatology. Okay, that is what sets this apart as a psychotic disorder first versus a mood disorder where mood is the predominant feature, and that has to be present with the features or symptoms of psychosis. Okay? Finally, as the name suggests, there has to be a mood disorder present that occurs at the same time as criteria A for schizophrenia, the positive, negative, and disorganized symptoms. The psychosis, meaning the delusions or the hallucinations, are present in the absence of major mood episodes. The mood is happening separately. Mood is a significant part of the presentation throughout, and you're going to specify the mood condition, meaning is it bipolar or is it depressive? This is going to conclude the video lecture. There will be a second module, but it's just going to be the slides because it's the relational aspects of schizophrenia. When you're doing the case presentations, I'm asking you about differentials. As we move through the DSM, you can see how understanding what the differentials are important. It draws your attention to what else could be going on, right? So when I'm asking about the differentials, it's because I want your mind and your thoughts to be broadened to consider that this could be something else because of the shared symptomatology, and my questions will help me to ferret out whether or not I am dealing with this working diagnosis or one of the differentials that could be associated. I realize schizophrenia spectrum disorders can be a little bit confusing, going from brief episode to schizophreniform to schizophrenia, but it is sort of a buildup. You start with delusional disorder, which is just a single symptom, and then you go to brief, which adds a symptom and a time frame of 1 day to 1 month. Then we move to schizophreniform, which adds another symptom, which is like a shorter duration version. Your schizophreniform is a shorter duration version of your schizophrenia, and then we move into schizophrenia, okay? And then finally we have the schizoaffective, which is equal parts schizophrenia and mood, either bipolar or depression. Okay, that should do it.